Perfect. Good afternoon, and thank you for inviting me. I'm a pediatric surgeon, and many of you probably know Dr. Aziz Khan, and I'm the understudy. So I got the privilege of coming this year for my first time, so I'm really honored to be here. I thought of Guts and Butts. You always want a good title to try to entice people to come to your talk because it's, the cover of a book. And so the other title I thought of when I was doing this talk was Down and Dirty, because we want to get the food down and, well, the backside stuff is dirty. That's what I do with my time at Cincinnati Children's. I am a colorectal surgeon, so I talk about poop a lot. The objectives of my talk, I have about 35 minutes. I wanted to talk a little bit about the esophagus, a little bit about Gtubes, and a little bit about the behind, and give my insights and some tips and tricks if I can. So I'll start with esophageal strictures. I've been under the tutelage of Dr. Aziz Khan for a few years now, and he's presented tremendously on the topic of esophageal strictures, and I've learned how to deal with these strictures from him, so I'm thankful to him, and I have a slide thanking him later. But basically, the esophageal strictures for patients with EB is different than esophageal strictures pediatric surgeons typically deal with for other types of issues that kids get esophageal strictures. Other issues are usually from reflux disease and from congenital malformations that may cause esophageal strictures. In patients with EB, the esophageal stricture really doesn't involve the mucosal lining. It doesn't involve the muscle, it only involves the mucosal lining. And so it's a different type of stricture, and obviously the issues involved with mucosa and injury to the mucosa attacking that stricture is different. The patients with esophageal strictures, and many of you I recognize in the audience deal with this, and we've seen, starts with dysphagia or difficulty swallowing and painful swallowing. First it starts with solid foods, then you go to puree foods, and then you're eventually on pure liquid diets. And that affects not only your swallowing and the pain and issues with swallowing, but it affects your overall nutritional status and your ability to heal. So once you see these symptoms, you have to start thinking, do I have an esophageal stricture? Is this what we're dealing with? The strictures then cause some downstream effects. Most importantly, could potentially affect the airway. You have coughing and aspiration or the stuff going down the wrong pipe. So some patients get respiratory issues from the aspiration, and like I stated before, it could affect your nutritional status. So you have weight loss, dehydration, and overall nutritional failure, which in turn will affect the way you heal. You have growth disturbances, and then families often complain of the meals take so long because the strictures are so, delay your ability to eat. The time at the table is so long because of the necessity to chew your food longer and really puree your diets, and that affects the whole family. This is an old slide that I borrowed from Dr. Aziz Khan, who borrowed it from years past, and it's basically stating that the recessive dystrophic patients clearly have a high probability. This is percent of patients requiring suffering with esophageal strictures and age in years. And all the recessive dystrophic patients suffer from this in a rather high percentage versus the simplex or junctional or dominants do not. Although it's not zero, they occasionally have issues. It's clearly not at the level of the recessive patients. So this is what a swallow study looks like for esophageal strictures. I'm going to state a few times that most esophageal strictures for this patient population occurs in the cervical region of the esophagus or the neck region of the esophagus. It's 60%, almost all patients, this is where it occurs. 60%, this is the only site that it occurs. About a third of patients have 2 strictures, and that leaves a little bit about less than 10% have 3 or more strictures. The way to diagnose to clearly diagnose a esophageal stricture, there's two ways. The best way is that by taking a good history. If you listen to the patient and hear their symptoms, you'll know that they have esophageal stricture. But if you want objective evidence for this, a barium swallow or a contrast study swallow is the way to go. And we caution that we've received many phone calls and reports, and I've spoken to a number of radiologists at other institutions where they say there is no stricture, but the patient is clearly having these symptoms. And it's very high up. Here's a study, contrast study, and here's the stricture you can see right here. And this is the patient's head, and the neck is right here. And if you don't inject the dye high enough and you pass your tube too low, and if your contrast study started right here, which is right at the level of about the shoulders or the clavicles, then you might miss the stricture. And obviously here is a very significant stricture, so you have to be very careful with that. Now, what my job is, and what I've learned to do, is how to dilate these strictures. How do you treat these strictures? And when you treat esophageal strictures for the other disease processes that I mentioned earlier, there's a number of techniques you could use. You could use something called the bougie or bouginage, where you take this big, firm tube and you just pass it through the mouth, down the stricture, and stretch out the stricture in a friction type setting to dilate the stricture. Obviously, friction in a patient with EB is not a good way to deal with the esophageal strictures. And we still see a number of patients that come to us that are having this type of dilation prior to seeing us. And so if you're going to have a dilation somewhere else, which is absolutely fine, make sure they're not using a bougie to do the dilation or putting a tube down the esophagus to stretch the esophagus. The other way to do dilations is using a balloon, and over the next couple slides I'll show you pictures of the balloon and how it works. You could do the balloon in one of two ways. You could use an esophagoscope, or when you get like an upper endoscopy, they use a scope to pass down the esophagus to take a look at your esophagus. They could also pass a balloon at that time to stretch out your esophagus. The negatives to that type of procedure is, again, you're passing something down the esophagus that may irritate or traumatize the esophagus, which in turn is really the cause for these strictures. These strictures are caused by trauma to the esophagus, causing blistering, and then the healing of that blistering causes the scar. So another way of doing this, in the way we do it, and I'll show you some pictures, is using fluoroscopy or x-rays or live x-rays to do the dilations. And it involves, I think, the least type of traumatic invasion to the esophagus in order to dilate the esophagus. This is just a little cartoon on how we do it. We basically pass a little tube down the esophagus, then we pass a wire through the tube, then we pass the balloon over the wire. Here's the balloon being blown up, starting to stretch the esophagus, and here the esophagus is stretched open. This is a picture of the equipment down in the lower corner, and here I'll show you a couple images that represent what I just showed. So if you look on the top of the screen here, this is the balloon being filled with contrast, and you can see this little narrow waistline, which is the esophageal stricture. This is what they typically look like for patients with EB. It's up in the neck region, and it's a single region where the stricture occurs. We then use pressure to blow up the balloon, and here in the lower you can see the balloon is blown up, stretching that stricture or that scar tissue in that region, which will allow it to widen the esophagus and allow for passage of more food and more solid material. This is what it looks like if you do it endoscopically or with the scope. Here's what a stricture looks like in the first panel. Here we're passing the balloon dilator through the stricture. Here you can see the balloon dilating the stricture. That's the top of the balloon right there. And this is the aftermath afterwards. You get, in many patients who've had esophageal stricture dilations, you may cough up a little blood for the first day or so. You can see right here, you see a little scar or a little damage to the mucosa of the esophagus, because that's where we stretched out the scar. And so that's what it looks like if you had a camera watching what we were doing. After we do the study, we typically put a little contrast in to make sure we didn't do any damage to the esophagus. What we fear the most, what proceduralists fear the most is doing more damage than good, or doing more harm than good when we do these procedures. And what we fear for this type of procedure is perforating or making a hole in the esophagus, and it's certainly possible. And so the best we could do is squirt some dye down after we do the stretch to make sure there is no injury to the esophagus. We typically give some steroids during the procedure in the short term after the procedure to help with the inflammation that is involved in these strictures. Studies have shown that if we biopsy these strictures, there's inflammatory cells there, and we try to limit the inflammation with a short course of steroids. This is just to keep everyone awake. I think it's a pretty funny slide. So now I'm going to move on to Gtubes. So when do you need a Gtube? That's the toughest question, and that really involves everyone who's caring for the patient. Most importantly, the patient themselves and their caregivers, because they really know when the patient is struggling to get the right nutrition for what they need to heal their wounds and grow. So there's no absolute numbers or facts that we could give that say when you should get a Gtube. It's a feeling. I want to say a gut feeling of when you should be thinking about getting a Gtube. Other reasons to get a Gtube are if you need frequent dilations. Instead of doing the dilations through the mouth and going down the esophagus in a forward direction, you could sort of do it in a reverse direction through the Gtube and going up. Causes less trauma to the oropharynx and the upper esophagus. And so if you're getting frequent dilations of the esophagus, it's a consideration to get a Gtube for that issue. Eating issues and behavioral issues, family dynamics are reasons to get Gtubes if we're having difficulty getting enough calories in. Approximately half of recessive patients require Gtubes, and a number of patients with simplex or junctional required in the newborn period. So it's really, the newborn period is a key period in learning the oral phases of swallowing, and I'm not a occupational therapist, a speech therapist working with swallowing, but if it's very important in the early stages to get the swallowing process down, and if you don't, a Gtube is necessary. Now, a Gtube does not, and this is very important, even if you get a Gtube, you still could eat by mouth, and that is very important and should be working on those skills so that you do not lose that ability, because once you get a Gtube, it's a nice safety net, but you should still be working on your oral skills. This is just a growth curve and a BMI chart demonstrating that if you fall off the curve, you get your Gtube, you could hop right back on the curve pretty easily. And so Gtubes do work. They work because you're able to get the nutrition in that you need. And here comes the but. Well, first I'll go into the techniques of doing the tubes, but then I'll talk about the but part of the Gtubes, which they have complications. So the technique for putting in a Gtube, there's multiple. Most surgeons are able to do what's called an operative gastrostomy, and we could put in a Gtube by either making an incision on your abdominal cavity and bringing up a Gtube that way, or we can do it laparoscopically if you have that skill set. So that's a way of putting in a Gtube and sewing the Gtube to the muscle where you bring up the Gtube, which is usually in the left upper quadrant of the abdominal wall. Then there's something called percutaneous gastrostomy tubes. That's, you could put it in two ways. It is something called the PEG. Many of you might have heard the term PEG. That stands for percutaneous endoscopic gastrostomy tube. That's when you use a scope to go down the esophagus, and a surgeon typically is on the abdominal wall and using a bunch of wires and tricks, and if I share all those tricks, then I won't have a job. Then we are able to get a feeding tube in place. The technique we like to use is something called a non-endoscopic push technique, where, again, we try to avoid as much trauma to the esophageal wall as possible, and we use fluoroscopy and image guidance to put in these tubes, and I'll show you a picture of that in a moment. From the, this is images of the PEG technique, and really whatever technique you need, this cartoon demonstrates what we need to do. We need to get inside the stomach wall, go through the abdominal wall, and come out the skin. A key possibility in a PEG technique, other than injuring the esophagus, is it's a little bit of a blind procedure. Somebody's going in through the stomach, that's the endoscopist, and the surgeon's coming through the skin, and we have to meet in the middle. Sometimes, occasionally, a loop of bowel gets in between there, and we don't know it. And we might not know that for 6 or 8 weeks or 12 weeks when we change the tube out. And that requires a big operation to fix the loop of bowel, or it's usually colon that sneaks in between there. So the PEG is a little bit of a blind procedure. So now here comes some of the issues with these procedures, the big one being granulation tissue. Those of you with Gtubes probably have dealt with granulation tissue. And to be honest with you, as a surgeon who's put in hundreds of more of these tubes, they're a pain in the butt. There is no perfect, first let me start by, we don't know exactly what causes it. It's a reaction of the skin to the tube. But worse is we don't know really how to fix it that well. We try to burn it. We try to chemically burn it. We try to cut it out. We try to put steroids on it. And sometimes they go away and it's great, and sometimes they come back. And it's really a difficult problem that we don't have the perfect fix for. I usually start by putting topical silver nitrate, so those little sticks that and try to burn it chemically. Then we use steroid creams to try to diminish the inflammation and bring the granulation tissue down that way. But here I'm showing 4 pictures of patients with granulation tissue, and we don't know how to predict this. And whatever type of tube you put in and whatever technique the tube is placed, open, laparoscopic, PEG, push technique, other, no one's found a way to get away from granulation tissue. So it's just something that if you have it, we have to work with you to try to limit the symptoms and try to solve the problem as best we can. The push technique is described here, and basically what we do is, with the help of interventional radiology, we put contrast in the colon so we can mark out the colon when we're doing the procedure. We put gas in the stomach to look at the stomach, and then using just percutaneous techniques, we put in these T-fasteners, or little stitches that sort of hold the stomach up to against the abdominal wall, and then using a number of techniques, we put wires and tubes in order to get the G-tube in the proper position. I think the key to the procedure, beyond those steps, which are all technical steps, is how we secure the tube after we're done initially. And we've been using these dental rolls around the G-tube and suturing the tube to the dental rolls in order to hold the tube in place for, usually we like to keep them in place for about 10 weeks before we switch them over, as this pictured over here, little buttons instead of the bigger G-tube in place. Try to limit the amount of injury to the skin in that region, and then I like to put a piece of Mepilex light in between the tubes so that there's less friction in that area. We do this technique for the older patients. For the younger patients, the neonates, the newborns, or smaller infants, we typically are doing either the laparoscopic or the open G-tube to perform the procedure because the colon, the bowel, and the liver are all too large and overlap each other for us to use this type of technique. Here's a little bit about Gtube Care. I'm going to skip this because we're all hungry. I'm going to get to make us not hungry right now and talk about the bottom. So I'm going to talk a little bit about anal fissures and a little bit about bowel management and my thoughts on those topics. And I think Dr. Farrell, who's speaking this afternoon in his title, Ins and Outs, will be talking more about the outs part in a little bit. So whatever perianal issue you have, fissures, fistulas, constipation, there are some common themes that hold true for all of these issues. Dietary management and hydration are all important. So getting good fiber in, and hydration in balance. It's not just about the fiber. You have to be hydrated as well. Help deal with these situations. I like to limit the time you sit on the toilet. I'll talk about what fissures are because many of you might not know what fissures are. My name is Fissure, not Fissure, not related. But I want to make that clear. But sitting on the toilet for a long period of time is not healthy for you. It could cause fissures, it could cause more hemorrhoids, and dealing with those could be quite painful. So a good 5 minutes or so on the toilet, and hopefully you should be done with the process. You could use Miralax or stool softeners or fiber, laxatives, all different types of agents that help loosen and move your stool forward. If you're impacted, you need to get disimpacted, and I'm going to talk about that a little bit in a while because you can't overcome impaction with simple stool softeners. And then this is the only part I talk about anal stenosis, so it's important to make sure that it's plumbing. If the hole's too small, it can't get out. So if you're having scar tissue or issues in that region, you have to make sure that that's taken care of. And so if you're having constipation issues and it's not getting better, make sure someone checks to make sure that there's not a stricture at the exit site. And you can treat that with dilations and whether it's dilations daily or in the operating room to dilate that lesion so that you could have help relieve the anal stricture. Anal fissures is basically a cut in your anus. It's a little, like a paper cut, a little bigger, but an anus, but they hurt tremendously. It is a very painful procedure. It could cause bleeding. So if you see bleeding on the toilet paper or on the stool itself or in the toilet water, that's often due to an anal fissure. And it's just a little tear in the skin. Here it is in schematic form. Here it is in real life. And then the other hint that you're having issues with anal fissures is that you get skin tags. Skin tags are the healing process of the anal fissure. And so if you have a number of skin tags, you've probably had a number of anal fissures. It could be due to hemorrhoids too, but in this case, it's usually due to the anal fissures. Again, here's some ways to treat anal fissures, and you'll see common themes: fiber, water, stool softeners. There's topical anesthetics. You could lidocaine, just like you get if you're getting your teeth extracted or dental procedures. There's creams and jellies that you can put in that area to provide temporary relief. I'm a big fan of baths. Baths are tremendous. It does two things. It keeps that area clean, which sometimes is very hard to keep clean if it's very painful. The other thing it does is it relaxes the muscle. It's not the actual cut that hurts. It's the cut is caused by your muscle, your sphincter muscle is in spasm because of the issues that are going on, and that's the pain that you're feeling. And so if you go in a warm bath, it helps relax that muscle a little bit, just like any other muscle, and helps try to relieve the pain. And if those steps don't help with the anal fissure, then you can move on to medical therapy. And medical therapy involves nitrates, calcium channel blockers. Those are both things that you hear for when you have cardiac disease. You take like a nitro paste or calcium channel blocker, helps with blood pressure and things like that. It works the same way. It's muscles that need to be relaxed. And those two agents help relax the muscle. You could get a Botox injection. Just like you get a Botox to relax, you have wrinkles on your skin and you want a Botox injection because you're getting a little older and I'm starting to get the little things around the eye. If I inject Botox there, it relaxes the muscle and you get rid of the wrinkle. Well, the same thing happens with the anal sphincter. If we inject Botox in that region, it relaxes the muscle and it helps with the pain and the issue at hand. And then if you're really, really having issues, you can get something called a lateral internal sphincterotomy. We make a little cut in your anal sphincter, which then relaxes the sphincter, which helps with the pain and healing of the anal fissure. And now these are some cute little pictures that you could get off the internet and go on and talk a little bit about constipation. I deal with a lot of constipation, and it's a very dirty process, and that's what that slide shows. And the other thing, this picture is from the New York Times Magazine. It's an ad for a hospital saying they do great cardiac surgery, and everyone loves to talk about cardiac surgery. My child had heart surgery, or my grandpa had heart surgery. It was 12 vessels. They were all occluded. It was great. He was the best heart patient ever. But no one talks about poop patients. You don't talk about it. They don't advertise it. It's not cool. And we're eating lunch soon. But we're going to talk about it for a minute or two. So many people in this audience, patients or other, probably have taken one of these two agents at some point in their life. My kids are on one or the other, and they switch back and forth, and don't tell my partners. But you're either on Miralax or X-Lax are the two most common agents that you're on. Miralax they work very differently. So Miralax works it's an osmotic agent. The colon, its main job is to absorb water. So when stool gets to the colon from the small intestine, it's liquid. When stool exits your anus, it's usually solid or near solid form. The colon, over the course of the time that the stool passes through it, absorbs that water. So what Miralax does is draws water back into the colon to help make the stool softer by bringing water into the colon, and that's how Miralax works. X-Lax is a stimulant, a laxative agent like Dulcolax. Those drugs work by stimulating the colon or making the colon squeeze more, and that works in two fashions. One, if your colon's not working well, it helps push the stool along, and then if the stool moves through the colon quicker, then it doesn't have time to absorb water, so the stool has a little bit more water content to it. Or is softer as well. And that's how those two agents work. I recommend that you don't mix them that much, or whenever you make changes in your bowel management regimen, whatever it might be, make one change at a time. Otherwise, you won't know what change helped you. Because I've had my daughter on Miralax, and she was soiling herself and all over the bed, and it was a disaster. And then I switched her after a lot of convincing to X-Lax, and it worked. I don't know why one worked or one didn't. Every patient is different. Every person is different. But I suggest that you just work with one, and if it doesn't work, try the other. Here are some of my key concepts to bowel management. How am I doing with time? We're okay. A couple minutes. I'm almost done, promise. Consistency. And I use that word in two forms. One is be consistent with your treatment process. I'm a big fan of being ahead of the game. If you treat your constipation because you're already constipated, you're going to have problems treating your constipation. If you treat your constipation before you're constipated, it should be more consistent. What do I mean by that? If you take Miralax or X-Lax after you feel constipated, well then, simple plumbing. If you're backed up with stool, and then you try to give something from above, like a stool salt, Miralax or something, it's going to make all the stool watery. The hard, constipated stool at the exit site is going to stay there, and then the liquid stool is going to leak around. And so if you're not empty, it's not going to work. And I really believe that you have to take whatever agent you want to use and however you want to do it in a consistent fashion, and not just be treating constipation after the fact. You also want your stool texture not to be rock solid, because as I described before, that's the biggest cause of fissures, is passing large hard stool through the anal canal. It causes a little tear, and then it's a vicious cycle of holding and pain and not passing the stool. Sometimes imaging is required to assess what the stool burden is, because like I just mentioned briefly, you could pass a lot of diarrhea and be massively constipated. And that turns into a vicious cycle of diarrhea, constipation, diarrhea, constipation. And as I stated before, diet. The adjustments is really a trial and error process, but you really want to make one adjustment at a time, so this way you know what works and doesn't work for you or your patient. So this is what a contrast study could look like if you get one, if you're constipated. You could see the white is the contrast study. This is the tube going up into the anus and rectum that injects it. And this is just large stool matter located within the rectum blocking the exit. And this could have a significant impact on the actual anatomy of your rectum, as demonstrated here. You could have massive stretching of your rectum. You could imagine how uncomfortable this could be if you are put in this situation. So if you could use laxatives or Miralax as your agents for emptying the colon, but if it becomes such a problem, you might need to use enemas to empty the colon as well. Here's a schematic and some of the tools used for emptying the enemas. In the extremely rare cases, if you're on enemas for a prolonged period of time, we could do something called an ACE procedure, which basically brings the appendix out the belly button, and you could deliver the enemas through the belly button in that way, but that's for a long-term use. This is what it looks like afterwards. And that's basically all I have. And I was given a 2-minute warning, so I have 2 minutes for questions. I'm happy to answer them. I want to say thank you to Dr. Lucky and Dr. Ziskan for inviting me on the EB team a few years ago and teaching me everything I know and learning so much, and still have so much to learn, but they've been great mentors to me. This is one of my funny slides. I found this driving down from Cincinnati through Kentucky. And that's it. If anyone has any questions. Yes.
My son has a Gtube and we deal with the granulation tissue and the stoma all the time, and sometimes it bleeds a little bit, but it's not really a big deal. Do I need to worry about it? Or can it just be there?
Granulate, it's scar tissue, so it's more of is the tube sitting in place? Are you having a lot of leakage? Is it damaging the skin around that region?
I always feel like it helps, if that makes sense.
There's not,
It lifts the butt up.
it's a protectant from the skin a little bit. It's the bumper. So other than that, it doesn't have any real problems. So it's not going to turn into anything, or it's the bleeding, it's the irritation, the skin, yeah. Someone over here had a question, yes?
Because the site of action is really in the large intestine where nutrient absorption doesn't really occur to
Right.
appreciable extent, with chronic use of softeners and laxatives, is it a concern that can hinder proper nutrient absorption utilization?
Using softeners or laxatives? I have patients that have been on laxatives and softeners for decades. And like you said, there's minimal, there is a little, but basically minimal nutrient gain from the colon. I take out colons all the time. Patients with ulcerative colitis get their entire colon removed and live just with their small bowel. We do not transplant colons, we only transplant small bowels. So there's no negative impact of making the stool move faster or anything, or using these agents. Miralax has not been tested long-term, but we know patients have been on it for decades. X-Lax actually has been tested, was taken off the market for a while because of concerns by the FDA, but then was put back on the market. The only side effects we know from using X-Lax or Senna products is that it causes a freckling of the colon, a melanosis coli or something like that. Basically, if you did a colonoscopy of patients on laxatives for long-term years, their colons look freckled. But they've biopsied it and haven't found any bad issues associated with it. No, they're not absorbed systemically, appreciably. I don't know all the other agents, especially in X-Lax, because they come in, X-Lax could be a chocolate square. My daughter takes it. She says it doesn't taste like chocolate. So for those of you that are out there, she goes, "Dad, this is not chocolate." I still get a treat. But as far as I know, nothing's absorbed systemically that causes any other issues. What you do have to watch out for if you take a lot of Miralax is your water. It's about a fluid balance, because if you're not allowing the colon to absorb water and you're taking 4 cups of Miralax a day, that could have an effect on your fluid balance. Yeah. Nope. Last question, I'm told. So the question is, how do you be proactive to prevent esophageal strictures? And that's the best way to be proactive is to prevent injury to the esophagus. So I think things like popcorn, things that are rough in texture, can cause injury. But I think more injuries caused by medical professionals. When you come in and we pass tubes and things like that, limit the amount of tubes and intervention to the esophagus as best as possible. And that's what we try to do. Even that's why I do the esophageal dilations just with wires and small tubes versus the esophagoscope and the bougies. So it's preventing injury. Popcorn being the food that comes to my mind when you could like sort of scratch your esophagus. And then I think more of the injuries come from medical professionals passing tubes and things like that. So we try to avoid patients having, if they're having nutritional difficulties and getting nasogastric tubes for feeds, eliminating that as best as possible and really putting in Gtubes so that you don't get injury to the esophagus.
Along those lines, are prophylactic use of H2 blockers, proton pump inhibitors, a wise idea?
Yes. I think in one of my slides, I probably skipped over it for time. You're absolutely right. Preventing the acid from coming up, because if you do get a blister or an injury to the esophageal lining, the acid is what causes the narrowing or the continued injury to that region. And so if you balance your pH of your acid refluxing up with an H2 blocker or proton pump inhibitor, so that's like Prevacid, things like that, that could be helpful. Great, thanks.